So it's my pleasure to introduce Jessica Stewart Gonzalez. Jessica has been working with children and family for over 20 years and currently serves as the office chief for the Office of Children's Health in the Bureau of Women and Children's Health with the Arizona Department of Health Services, where she has worked for the past 10 years. Currently, she oversees more than $30 million in state and federal funds across the maternal, infant, and early childhood home visiting program, or MECSH, high-risk perinatal program, sensory screening program, children and youth with special healthcare needs program, and the Strong Families Arizona Helpline, Arizona Maternal Child Health Helpline, as part of the Maternal and Child Health Block Grant. Additionally, Jessica is an integral part of the state home visiting system, managing the statewide data management system, administering the Strong Families Arizona Home Visiting Alliance. And now I'd like to turn it over to Jessica, who will present on the Arizona High Risk Perinatal Program and a MECSH pilot. Jessica, welcome.
Thank you so much. So as mentioned, I am Jessica Stewart Gonzalez, and I am the office chief for the Office of Children's Health at the Arizona Department of Health Services. And I get the opportunity today to talk about our high-risk perinatal program with a focus on the community health nursing component of the program and the pilot project in which we are utilizing the maternal and early childhood sustained home visiting program, which in acronym city is called MECSH, with a community nurse serving our high-risk perinatal program families. In this section, I'm going to talk more broadly about what the high-risk perinatal program is, what the mission is, the history of the program, and then go over what the program components are and how people enroll and participate in the program. To get started, I just wanted to ensure that everyone had an understanding of what the mission of the high-risk perinatal program is, and then we'll go into a little bit about how we work to accomplish our mission. The HRPP mission is to reduce maternal and infant mortality and morbidity through a regionalized statewide system of coordinated care that includes consultation, transport, hospital care, and community health nursing follow-up. HRPP has been in existence since the 1960s and is one of the longest standing efforts to address maternal and infant mortality and morbidity in Arizona. I want to provide a history of the program, not only because it is impressive to see how time and effort can create impactful and positive change, but because it also allows you to see how the program has adapted to the needs of the families it serves and continues to do so. I know some of these boxes are a little small, but there's a lot to cover. In the 1960s, there was limited and inadequate care for premature infants, and Arizona had one of the highest infant mortality rates in the country. In 1967, in an effort to reduce the infant mortality rates, Arizona applied for and received a federal demonstration grant, and that grant was designed to reduce infant death, specifically for transporting critically ill newborns from rural hospitals into intensive care centers. And as a result of those efforts, there was a dramatic decrease in infant mortality between 1967 and 1972. Because of that decrease and because data matters, in 1972, the state legislature provided state funding for the program, and it officially became known as the Newborn Intensive Care Program, or NICP. In 1975, Arizona received the Robert Wood Johnson Foundation grant to develop regionalized perinatal care with a focus on the maternal transport system. Under this program, Arizona began to develop the guidelines for level 1, 2, and 3 perinatal hospital services, a perinatal data system, and the system for maternal transport. In 1977, it was demonstrated that infants did well if transported back to hospitals closer to their homes following the acute phase of their illness. Therefore, back transport was then added as a component of the transport system of NICP. This not only allowed for babies to continue to receive the appropriate level of care based on their need, but it also supported families in being able to be in closer proximity to their infants. In 1980, carryover funds from that Robert Wood Foundation grant In addition to grant funds received by St. Joseph's Hospital and Good Samaritan Hospital, were utilized to establish the Arizona Perinatal Trust. And this trust is dedicated to improving the health of Arizona's mothers and babies and supports Arizona's regionalized perinatal care system. In the late 80s, the ADHS Office of Women's and Children's Health, with the county health departments, identified a need for home-based community health nursing services. And at this time, it was specifically to address those that weren't necessarily critically ill at birth, but were diagnosed with problems at a later date. And this was also during that time in which Part C, which used to be previously Part H, of the Public Health for Individuals with Disabilities Education Act was enacted. So there was a lot going on. In the 90s, IDEA provided incentive for the development of a system of early intervention services, which could provide a comprehensive, culturally appropriate, multidisciplinary, and family-centered approach for all families. And we were allowed to utilize those funds to create developmental clinics to determine eligibility for AZIP, or the Arizona Early Intervention Program. But like all good things, it had to come to an end in 2002 when funding for that developmental clinic component was eliminated. This left physicians and therapists with few options for evaluating developmentally delayed patients. And physicians began working closely with the legislature to restore funding for this service. And in 2007, it was partially funded through the state legislature and allowed developmental assessment to program enrollees in HRPP who did not meet the AZIP eligibility criteria and were uninsured or underinsured. During 2009, as some on here probably and painfully remember, the state experienced a severe budget downfall. And the result of budget reductions, the program had to look at the legislative requirements. All of the components of the program that were taking place, eligibility criteria, and how to better support the prevention efforts so that the program's impact could continue to be successful. So to make this shift, the program, the NICP, was renamed to the high-risk perinatal program. And for a period of time, we had both names going on, but it has fully transitioned and is the high-risk perinatal program. Some of the other changes that came as a response to that reduction is that eligibility criteria for the program was reduced so that way services were available for the sickest infants. It also expanded the distance for back transport eligibility, and it eliminated that developmental assessments within clinics, but it was switched to utilizing the CHN, or the community health nurses, to do developmental assessments as well as provide prevention education by incorporating postpartum wellness, in interconception health education, and now on mental health screenings as well. The program continued to make progress by transitioning to the statewide home visiting data management system, which allows for better integration of services, aggregated statewide data, and more efficient response time to hospitals, physicians, community health nurses, and families, because we now had access to real-time data. In 2019, an idea sparked that we could further support HRPP eligible families that needed more of those intensive in-home supports by utilizing the maternal and early childhood sustained home visiting model curriculum, which is an evidence-based nurse home visiting model, and allowed opportunities to access other funding sources to further support the program. From that idea came several years of work to develop and execute a pilot. And as of a few months ago, we do have our first HRPP enrollments in the pilot program, but we're going to go into a lot more detail about the pilot program later in this session. But that brings you up to date, and you are now caught up on the entire history of HRPP and the 55 years that it has taken to get us to where we are. When I started preparing this section, I started with saying, I'm going to give a brief history. And as this came out, this is not a brief history. There is a lot that has happened. I'm also the daughter of a historian, and so there's probably a little bit of that, and I couldn't leave anything out because, as we know, history matters. So where does that actually leave us right now, and what does the program look like? So right now the program has 3 components. We have transport services, hospital services, and the community health nursing services. The transport services includes the consultation line and the transport services. And the consultation line is a 24/7 phone line designated to assist physicians throughout the state in getting their high-risk pregnant patients or critically ill newborns to a hospital with the appropriate level of care. So maternal fetal medicine specialists and neonatologists take calls to provide expertise to those providing care to their patients if that provider does not have that level of expertise. Part of their role is to provide that consultation, but they also help determine if the birthing person or the newborn needs to be transported to a higher level of care and or have received the care and are ready to be transferred back to the original hospital. HRPP contracts with ground and air support companies that have specially trained high-risk teams to provide care for the pregnant person or infant during their transport. Transfer approvals may happen within the hospital system, so such as like a Banner emergency department to a Banner hospital with a NICU, but then the transportation that is needed for that transfer is coordinated through the transportation line. HRPP contracts with hospitals across the state that are certified by the Arizona Perinatal Trust. Hospitals provide developmentally and risk-appropriate care for the newborn until discharge. And the hospital enrollment support services reimburse the contracted hospitals a fixed price for each enrollment into HRPP, and contracted physician groups can also submit claims for their services for reimbursement. Contracted physicians provide comprehensive care to critically ill infants while in the NICU or special care nursery, and they agree to charge families no more than the HRPP family liability, which leads us into the financial assistance for families component. Financial assistance is specifically for the infant's NICU stay. And we know that staying in the NICU, we know that that can be incredibly expensive. It doesn't matter how long you're there. It is a very expensive stay. Families that are fully enrolled in the program can complete a family liability enrollment in which the total amount they have to pay for their medical expenses is calculated. So this takes into consideration other medical bills paid, income level, and the hospitals and the physicians contracted agree to not bill the family more than their established family liability. And that information is shared between the program and the hospital and physicians. Once the family pays their family liability amount, they do not owe any additional hospital or physician bills that were within the HRPP network. Family insurance is billed, and HRPP does serve as a payer of last resort for those inpatient physician care costs. And then we have our community health nursing services. So regardless if you're enrolled if you're enrolled in HRPP or enrolled in our HRPP pilot program, they can receive support and home visits until the baby is 3 years of age. The cadence of the visits does depend on where they are in the program, the need that the family has and which track they're in, and we'll go into that in a few minutes. So how does one qualify for the program? There are quite a few ways in which babies are eligible for the program, and there are varying levels of services depending on eligibility criteria as well. So families must be a resident of Arizona at the time of their infant's birth, and have babies that need an intensive or special care nursery for more than 120 hours or 5 days immediately following their birth. Or they are infants that might have been discharged home from a well baby nursery at the hospital, but might be readmitted to an intensive care unit or a special care nursery within 96 hours of birth. There are also situations in which a neonatologist may specifically request that that baby be seen by the program depending on the individual needs. And then there are also situations where maybe a baby is born in another state, but they do reside in Arizona. And then when they return home, when they're able to return home, if they were in a NICU in another state, then they could qualify for our home visiting services as well. Any baby that has a diagnosis of NAS are also eligible, and they are not required to meet that same 5-day stay in the NICU. They are automatically eligible for HRPP, and then they do need to reside within a service area. Depending on your eligibility, would depend on if you qualify for all or only part of the HRPP components. So in HRPP, there are two enrollments. You can either have full participation or partial participation. That full participation includes that financial assistance piece that we talked about, and then plus the community health nursing component. And then the partial participation is only, there's no financial assistance awarded, but the community nursing program is available. And I know some of you are thinking, why in the world would anyone not enroll for full participation? But there's several reasons. They could just not qualify. So for example, when we were talking about eligibility and that example that maybe the baby was born out of state and had to have a NICU stay, since those services were provided outside of Arizona, they don't qualify for that financial assistance since they weren't in an Arizona Perinatal Trust hospital that's contracted. But they do qualify for home visiting through the community health nursing services. We do work directly with the hospitals. They are the ones that primarily enroll into the program, and they help create those systems and processes that support families in fully enrolling if they are eligible to do so, and to make sure that anybody who is participating in the program is able to have as much relief and as much assistance as possible. Now we'll go into more of the specifics of the community health nursing services and our pilot project. In this section, we'll review the objective of the community health nursing program, the process for supporting families transitioning from the NICU home, the service area that the program covers, what the home visiting schedule typically looks like, and then what topics are usually covered during the home visit. So the objective of the community health, the community nurse services have changed throughout the years. And as you saw in the timeline, right now, the community health nursing for HRPP is designated to assist in the smooth transition of medically fragile infants and their families from the NICU to home, and to provide home visiting services that can be tailored to the needs of the family, that are family-centered and appropriate for the child. And additionally, the role of the community health nurse is also to provide referrals to other community resources and other programs and services, just to make sure that families are connected to what they need. To accomplish the objective of assisting the transition from home from the NICU, the hospitals have HRPP liaisons that support the completion of the necessary documents and information of the family into the data management system, so that the community health nurses can receive what they need to contact the family and schedule that first visit, and so that they have some history on that baby, so that they can be prepared for the type of support and services that they would be offering. The liaison does complete the referral to the correct CHN service area, and then that CHN connects with the family within 7 days of being discharged from the hospital. There are not CHN services that are available everywhere. We do have, while we cover most of the state, there are some gaps in those services. And in those instances, they are referred to other support services within their community. This map, although maybe a little bit hard to see, shows the service areas that the high-risk perinatal program has community health nursing services in, and also shows how that service area, how those service areas are put into those regions. The community health nursing providers are determined by a competitive procurement process, which happens every 5 years. The CHN providers provide services throughout their designated region, and they do accept all referrals for the program. Areas in which the program is not available, as I had mentioned, hospitals do make referrals to other supporting programs in their area, such as other home visiting programs that they might be eligible for. So the schedule for home visits does depend on the needs of the family, but an optimal community health nursing home visiting schedule during the first year would include 6 visits, which is an intake visit, and then one at 2, 4, and 6 months, and then between 8 and 9 months, and then at 1 year. Visits can continue until the child is 3 years old. And during that year 2 and year 3, there should be at least 4 visits, depending on the child and the family needs. So what happens during those home visits? During each of the home visits, the community health nurses discuss various topics depending on the age of the child, and they include things like assessing and learning about child development, the maternal health needs, nutrition, safety, so things like safe sleep and car seat safety, but also things like home safety, especially as babies become more mobile, and then school readiness skills such as early language and literacy. Since children enrolled in the program already have some history of critical health needs, it is always appropriate to provide that information and education based on their specific needs and not always on typical development or milestones. So CHNs also adjust those topics and how the topic is discussed to ensure that it is appropriate for the child and the family and where they're at. Some of these considerations might be the adjusted age of the child, any delays or disabilities that might have already been identified, how their nutrition is received. Obviously, how you have a conversation about food is different depending on how they receive their nutrition, or if they receive it in an alternative way, such as through a G-tube. And if they might be going into or recovering from medical procedures. So we know that some babies may leave the NICU with a condition that is identified, but might need to wait to be addressed until they are bigger or stronger. And so they could be going back into medical care that could also impact how and why topics would be addressed during a home visit. Or may have a child or parent with specific needs, such as addressing substance exposure. So while there are general topics or assessments that take place as part of the program, the benefit and the purpose of the CHN services is to ensure that families have flexible and adaptable services as well. We are very proud of the CHN services and that serve the families and receive the services. Those that receive the services often express their gratitude for the support that's received. However, we know that there's always areas of improvement to address the gaps that even the best of programs have. So some of the challenges of the community health nursing services include program dosage. So since participants receive 4 to 6 visits per year, it's not going to address all of the needs or support that every family may need. For some families, that is perfectly what they need. For some, it might even be too much, but then there's others where it's not necessarily, they could benefit from having that higher dosage of services. If a family is identified that could benefit from a higher dosage of services, a community health nurse is limited in their capacity to meet that need. Their caseloads are high, and home visiting programs that serve a high acuity population have a maximum caseload capacity, typically in the 20 to 30 families range, which is only about 15 to 25% of a CHN current caseload. Families that could benefit from the program with a higher dosage of services are limited in available programs. So while Arizona has many home visiting programs throughout the state, there are limited options for nurse home visitor programs. And the one that is currently being implemented the only one previously being implemented, is limited to urban areas and only to first-time pregnant people prior to 28 weeks pregnant. So HRPP eligible families do not typically qualify for the other nurse home visiting program. In order to meet the needs of some of the families that are enrolled in HRPP, we would need to reduce caseloads and increase dosage, which we know that type of change takes a significant shift in funding. In addition to specific challenges of HRPP, we always look at home visiting services through the lens of our statewide home visiting system. And this allows us to assess for opportunities to address barriers, or allows us to see where barriers may impact a larger population. So in examining the other barriers to accessing a nurse home visiting program that is not HRPP specific, we found that individuals that are pregnant or parenting more than one child were not eligible for another nurse home visiting model. A nurse home visiting model is expensive, and we do want to be able to provide nurse home visiting services that are also cost effective. Many home visiting programs only go until the child's second birthday, which leaves a gap in available services between the ages of 2 and 3, when a child may no longer qualify for available home visiting services, but may also not be starting preschool until they are 3. And lastly, as we have heard over the past 2 days, there are some very specific concerns in Arizona that impact the maternal and child health outcomes, and a program that is flexible would be really beneficial. So what do? We brainstormed and identified that there is an evidence-based nurse home visiting program that we wanted to learn more about and to see if we could potentially address some of the barriers identified. So that brings us to our pilot program. For the maternal and early childhood sustained home visiting model, as you have heard, is called MECSH. And we will go over what that model is, what is the target population, and what benefits there are to the model, and if it supports our desired outcomes. We'll also review how the feasibility of the pilot project was determined, our strategic planning process, and implementation. So the Maternal and Early Childhood Sustained Home Visiting Program is an evidence-based home visiting model that aims to improve the health development and social well-being of families with new babies in need of additional sustained support. So it supports positive transitions to parenting, positive parenting skills, future-oriented and aspirational thinking, that goal setting, problem-solving skills, and the ability to mobilize resources and healthy relationships. I do just want to take a minute to further explain what we mean when we talk about an evidence-based home visiting model. Since you've now heard that a couple of times, the home visiting evidence of effectiveness review, or what some know as HOME-V, because we love our acronyms, launched out of the Department of Health and Human Services, and it completes transparent reviews of home visiting model research evidence to determine if the evidence demonstrates positive impact on maternal and child health domains. And if they meet those specific criteria, then it's deemed an evidence-based model from the Department of Health and Human Services under HOME-V. This determination is only relevant to this discussion because you'll see in a few slides that funding for the pilot program are federal funds, which do require that funds are used specifically for an evidence-based home visiting model. So who qualifies for the MESH model? Individuals that enroll in the program must be either a pregnant person or a parent or caregiver with a newborn up to 8 weeks post discharge from the hospital. So the pregnant person aspect is important because they could be at any stage in their pregnancy, and it doesn't matter how many times they may have been pregnant before, they are eligible for the program. A parent or caregiver with a newborn up to 8 weeks post-discharge from the hospital is really important for our HRPP population because we know that babies have various lengths of stay in the NICU. And for some, by the time they're discharged, they no longer are eligible for some of the other home visiting programs. So this program allows for that 8 weeks post-discharge from the hospital and not necessarily the age of the baby. A parent or caregiver also would demonstrate that they have psychosocial, demographic, or other health characteristics that place the child or their family just at risk of poor health and development. And we say demonstrate because that's the model language, but everything is self-reported by the individual. All of the assessment tools that are utilized are done by the individual. We are not determining or telling anyone what their health characteristics are in that assessment. They share that information if they would like to. And then similarly, a parent or caregiver can self-identify just as needing additional support to adapt and manage the transition of a new baby, which I think probably qualifies everybody regardless, because that transition is really hard. The model addresses some of the barriers that we previously discussed because of the wide eligibility net that it has. So while the program has many benefits that do impact maternal and child health, I did pull out the specific benefits that address the gaps that we talked about previously. So this model does provide opportunity to serve high acuity families and has a caseload capacity of 25 per nurse home visitor. This model is not only designed to support families in becoming self-sustained, but it also aims to sustain services by limiting or eliminating model-specific costs without eliminating model-specific training and support. And as already seen, the eligibility of the model addresses some of those current gaps as well. The MECSH model offers both a 2- and a 3-year program, and to not only align directly with the CHN, the current CHN services, but also to address the need for more programs that provide services between the ages of 2 and 3. We decided that we would implement the model under the structure that allows services through the child's 3rd birthday. This model also addresses the need for a higher dosage of services, with having 35 home visits as part of the program. And I added that plus to the 35 because the model is very flexible, and in any time there is a need or a specific situation that may come up for a family, the nurse home visitor has the ability to provide additional home visits and services as needed, even if it is outside of that program schedule, to ensure that families are getting what they need and they are able to meet their personal goals as well. And then the last benefit to highlight is the flexibility of the program and how it is implemented. So we'll see in a few slides, we'll see in a few slides the modules that were selected for the Arizona program that were specifically selected based on the needs of the state to address maternal and child health priorities. But we also have the expertise, they also have the expertise to help create modules based on our needs if we specifically wanted to include something within the home visiting model that isn't already available. So then, since the model target population and benefits checked many of our boxes, we decided that we would move forward with exploring the option of implementing the model and with following desired outcomes. Multiparous people and families with critically ill newborns are able to receive services through an evidence-based nurse home visiting program for up to 3 years and will improve maternal and child health outcomes, one of our goals. And then the other one in doing this is to execute a pilot program specifically for the high-risk perinatal program to determine if a more intensive services, increased dosage of services would result in better outcomes for families that self-identify as having a higher need. And that is done through the Adapt and Self-Manage tool, which has all of those components that we talked about in regards to those health characteristics. So once it was determined that we wanted to further explore that this model potentially could work, we wanted to further explore and determine if it was even feasible to do so. You can have a great idea, but if it's not feasible to implement, then it doesn't matter. So we took a look, of course, at funding. So funding from the Maternal, Infant, and Early Childhood Home Visiting Program, which is MECSH, could support the cost of the pilot program, as it is an allowable evidence-based model. So that's where that evidence-based criteria was relevant as well. Funding was available through the American Rescue Plan for MECSH, specifically for program implementation use that would be time limited. And funding was available for 6 nurse home visitors that would allow for a caseload capacity of up to 150. And that is broken down by non-HRPP eligible and HRPP eligible. So we have MECSH non-HRPP eligible, which would be 5 nurse home visitors with a caseload capacity of 125. And then the high-risk perinatal eligible would be 1 nurse home visitor with a caseload of 25. MECSH has that Adapt and Self-Manage tool that would assist in identifying which track, so the community health nursing or MECSH, HRPP eligible participants would benefit from, in addition to discussing options with the family. So this allows us to more appropriately select those that would benefit from that higher dosage program. So since we now figured out the model that could potentially address our barriers, and we've determined that it was fiscally feasible, we moved into that implementation. So I know it's a tiny map, but this map is really just there as a quick reference to talk about how that determining the location for the pilot program. So this just shows you that reference for our primary care area boundaries and those, or PCAs. because the way that the data is done is not specific to necessarily counties or zip code or cities. It is from these primary care areas. These are boundaries that are not, that ADHS uses as a rationale service plan area for federal shortage designations related to primary care, dental health, and mental health. And so we collect and report data based on these geographic boundaries, including the 2020 MCV needs assessment. So we just continue to use those geographic boundaries for this assessment as well. So there's 126 primary care areas, and each of those areas were looked at under 6 indicators, and then identified whether or not those indicators were less than, equal to, or more than the state average. And that includes those that are in bold. So HRPP enrollment, NICU admissions with subsequent pregnancies, race and ethnicity of live births, prenatal care in the first trimester, no prenatal care, and then Medicaid paid birth. Additionally, we had some data that was also reviewed to further determine the risk and need, but may not have been PCA specific. And those include those areas that are within the 2020 MCV needs assessment. We did look at the number of live births, caseload capacity for the home visiting programs in areas. And then we also looked at data from the PPOR and PRAMs to really give us that bigger picture of what we were looking at. So of the 126 PCAs, I'll run down through this as quickly as possible. Of the 126 PCAs, 16 of them did not have any indicators that were identified as out risk, which means they weren't worse than the state average. 27 of the primary care areas had 1 indicator, 29 had 2, 26 had 3, 17 had 4. 10 had 5, and then we had 1 primary care area that had all 6 indicators that indicated that they were worse than the state average. Then we took those additional pieces that we were looking at, now that we have looked at our PCAs, to identify these other criteria that were needed in order to be able to do contracting and use of funds. So of the 11 PCAs that had 5 or more, then we looked at whether or not they were also within the 2020 MCV needs assessment. So that narrowed that down to 4 of the 7 could not meet that expansion. Sorry, of the 11, 5 and 7 were identified as at risk in the needs assessment. 4 of the 7 could not meet the expansion of the proposed caseload criteria. And one of the reasons why we're looking at that is because we don't want to increase competition of resources or oversaturate a community that already has home visiting programs that aren't already at capacity. And then 1 of the remaining 3 communities did not have both a MCV and HRPP contractor in the community. So this resulted in a total of 3 communities that were identified as potential pilot sites. Those communities are the primary care areas of Tucson Central, Tucson Foothills, and Tucson South. And they were determined to be at risk and would benefit from expanded nurse home visiting services within their community and the use of the maternal and early childhood sustained home visiting program. These PCAs had higher than state average in at least 5 of the 6 indicators. And there was a gap in services, ensuring that there would not be an increase of that competition of resources or oversaturation. And this chart just shows how all of that analysis came together in a pretty little chart. So now we had identified that, where the pilot program could be implemented, and we now needed to decide how it would be implemented and what the program would look like. So the MECSH model has 5 domains and various modules under each of the domains. Regardless of where the program is implemented, there are 4 modules that are required for model fidelity, and then everything else is selected based on the need of the state. So in looking at some of those other reports and some of the information that we have, we identified that managing infant safe sleep issues, oral health, maternal mental health and well-being, and family violence were specific ones that would benefit the families in Arizona. And then we also selected the substance exposed newborn and maternal substance use module, which goes across all of the domains. From those selections, the model developer created a specific program, including training, the home visiting schedule, and all of the materials, and then aligned with all of our modules. So now we had everything that we needed, and we were ready for full implementation. So as you saw in the community selection table, the contractor had to be in the community that needed to be served and already implementing MECSH and HRPP services. And so the programs had identified that East Sills Blake Foundation is the proposed local implementing agency, or LIA, for model implementation. East Sills Blake Foundation does currently contract for MECSH and HRPP funded services and had the capacity to expand services while providing high quality supervision, engaging in the evaluation and the pilot program, and participating in continuous quality improvement efforts. All evidence-based home visiting models also have a national, or in this case, an international model developer in order to utilize the curriculum and materials, and that has also been completed. The international model developer for MECSH is in Australia, out of the Western Sydney University. And then now we needed to train everybody. So we had everything that we needed. All of the training was a 5-day training, and all of the nurses that were already hired for the expansion and the high-risk perinatal program nurse all attended training in March of 2023. And then we started in that process of doing the data setup that we needed within our data management system, making sure that we had all of the forms that were needed and everybody was trained not only in the model implementation, but also in data collection and reporting. So now we're in full pilot mode. Enrollment started in June of 2023, and 8 out of the 25 caseload slots for the HRPP nurse are filled and data collection is taking place. And we'll continue to collect and analyze data as well as collect information from those implementing the model to learn about what it looks like in action and if there are areas for improvement. Since this is a 3-year program, we anticipate that it will take our 3 years to have a full report of outcomes. But throughout this whole process, we will continue to share information and progress throughout the implementation time. We have worked very hard to get to where we are, and we are excited to be able to be in a place where we can share the process and the progress of the work. I know this might have felt a little anticlimactic since we aren't able to share any outcome data. You're brought right up until the implementation piece of our pilot project. But it's important that we also share what it takes to address needs and make changes. We look forward to being able to give updates throughout this process and to see how the high-risk perinatal program continues to adapt and address the needs of the families that it serves. So I am happy to take some questions if there are. I also have Laura Bellucci here with me as well in attendance to help answer questions, depending on what you have to answer and if I have the ability to answer them.
Thank you. Thank you, Jessica. I really appreciate the detail in terms of how you identified the community that had the greatest need. It sounds like it's not as simple as it may seem, but I appreciate that detail. So we do have some questions that have been coming in through the chat, and some have been responded to by Laura. So what I'd like to do is ask the questions, pose the questions to you that have not been responded to, and then we'll go back to the questions where there have been responses, if time permits, for you to continue to provide your perspective on it. So the first question is from Jasmine Marquez, and she writes, are nurse home visitors meeting the families registered nurses similar to the nurse family partnership program?
Yes.
Okay. The next question is MECSH considered a duplication of service from other home visiting programs such as Healthy Families?
Yes. I like that. I
Okay.
like these. I like the ones that I know the answer.
Let's go to the top of the first questions that were coming in. And again, I'll read you Laura's response and you can add anything you'd like to it. This is from Kate Doppler. She asks, what is the coordination with the Arizona Early Intervention Program for infants in the high-risk perinatal program? Laura's response, the coordination of referrals, including AZIP, would take place during community health nursing visits with the family. Is there anything else that you would like to add to that?
No, that is correct. I'll just expand, I guess, a little bit. So yes, just that they do complete the ASQ, so the ages to stages questionnaire, in order to make those determinations for the referral.
Thank you. The next question reads, this is from Natalie Kaufman. If a facility is contracted with HRPP, do they have to utilize a transport company that is also contracted with HRPP? Laura's response was, the short answer is no. They don't have to put it, they don't have to, but it depends because transport either are coordinated through a consultation line and or come up once an infant is connected with the program. The program does have the ability to pay off contract transports, but the condition of the transport depends on if the infant is HRPP eligible.
Yes, nothing to add there. That is correct.
Okay. Laura's getting an A today then.
I know, I like it, thankfully.
Yeah. So this next
some,
question is
ones.
from Karen Kelsch. What are the differences between this program and the Healthy Families or Smooth Way Home? Laura's response is HRPP eligibility starts while infants are still in the NICU. HRPP has community nursing models after discharge to follow that infant after discharge. Smooth Way Home and Healthy Families are different models offered in the state that also support infants and families.
Yeah, the greatest difference between any of the home visiting models or support services really fall under eligibility and whether or not that family meets those specific parameters.
Okay, two more questions. This is from Robin Richardson. Can you please define fetal mortality? Does the baby have to have taken a breath, or are SAB, fetal demise, and stillbirth counted in those numbers?
That is not my area of expertise, and I will we'll either have somebody answer that question, or if somebody else on here, Martine or somebody, may have more
Martine just
better description.
What, Dave?
Yeah, Martine just answered
the question.
Oh, okay, perfect.
Okay. The next question is, Nurse Family Partnership has been doing this for many years. Are the standards and research reflective of their work? That's from Tracy Hughes Hamilton.
Can you repeat that question?
Sure. Nurse Family Partnership has been doing this for many years. Are the standards and research reflective of their work?
Absolutely. I mean, and that's where the evidence-based component comes in, because all of the home visiting programs, or those two specifically, both MECSH and NFP, are evaluated under the same criteria under home fee.
All right. Thank you so much, Jessica. That concludes the questions that came in through the chat.